All right, great. Hello, everyone. Let's go. Yeah, I'm Friedrich, one of the EM registrars. I think I've met, I suppose, most of you. I'm going to talk to you about vasopressors and inotropes. So we are going to discuss, we'll quickly go through different vasopressors and inotropes. Then we'll talk about targets for titration, hemodynamic effects, when to start second-line drugs, and then just some myths and administration of inotropes. There's different effects on the heart from inotropes and vasopressors. I suppose we mostly talk about chronotropic and inotropic effects, but there's also bathmotropic, which modifies the degree of excitability of heart muscle. And there's dromotropic, which affects the conduction speed in the AV node. And then chronotropy, which changes the heart rate. Lusitropic, enabling the heart to relax. And then inotropy, which alters the strength of contraction of heart muscle. We are going to discuss all these pressors, but this is the table that you can go and sit and memorize tonight. Let's start with adrenaline, also known as epinephrine in other parts of the world. It acts on alpha 1 and 2 and beta 1 and 2. And the most important thing there is we can't get alpha without beta. Quick onset, up to 2 minutes, sometimes only in a few seconds. The side effect, the issue here is it flogs the heart, which leads to increased oxygen consumption. We use it mainly, well, we're supposed to use it mainly in the AAA shocks, so anaphylaxis, asthma, and the rest. But in South Africa, we use it pretty much for all our shocks. At low adrenaline concentrations, it has a higher affinity for beta-2 receptors. Therefore, in lower doses, the beta-2 receptors will be occupied first. And then as we increase our adrenaline concentration, we will only start seeing alpha receptor features. So they say you should never run your adrenaline below 0.05 mics per kg per minute. Yeah, as you can see, so adrenaline is more beta than alpha. Bigger effect on heart rate, inotropy, ectopy than it has on our systemic vascular resistance. Dobutamine. So this is a pure beta agonist, quick onset of action, but some delay until we see the peak effect. So we shouldn't titrate up too quickly when we start this. The main effect here is mainly inotropy with some mild vasodilation, and we will mostly use this in cardiogenic shock. The problem here again is it flogs the heart. So as you can see, mostly beta, some alpha, increased effect on heart rate, inotropy, and ectopy, with a decrease in systemic vascular resistance. So while increasing the cardiac output, there's a variable effect on blood pressure. So starting dobutamine in a cardiogenic shock can actually drop the blood pressure. Noradrenaline, so it works on alpha 1 and beta 1, but most alpha more than beta. Quick onset of action, short half-life. Main effect is vasoconstriction, and that is what we want for the main shock use here, septic shock, but we can use it in all shocks. Side effect here is bradycardia and arrhythmias. And as you can see, the target is mostly alpha. Yeah, effect on systemic vascular resistance is more than effect on the heart. Dopamine, some people don't like dopamine. And the reason for that is, if you look at the receptors, it's a dirty drug. There's a lot of receptors involved. It's alpha 1, alpha 2, beta 1, beta 2, and the dopaminergic receptors. Quick onset of action with a short half-life. Another issue with this, with dopamine, is its metabolites is active. It causes vasoconstriction in higher doses, but it can also have some effects on inotropy, domotropy, and chronotropy. Main shock use is hypertension, and the side effect, it can cause tachydysrhythmias. So you can see there's different effects depending on the doses that you use for dopamine. Low doses will only work on dopamine receptors, and as you go higher, you'll start achieving your effect on your alpha receptors. Phenol, your pure alpha agonist, quick onset of action, with quite a long half-life, but the duration of action is short, 5 to 20 minutes, which makes it a great drug for peri-procedural bolus doses. So think of the patient that you want to intubate that's develops hypotension after giving your drugs. So main effect is vasoconstriction and great for push dose pressor. The side effect here is your reflex bradycardia. Iso something, let's just go with that. Another pure beta agonist. Quick onset of action, short half-life. The main shock used here is is anything cardiac, so bradycardia, heart blocks, cardiogenic shock, and then also refractory to SARS and bronchospasm. We don't have this in Gauteng. I think they might have it in some private places, or I've heard in the Western Cape, but otherwise the guys going on the ships overseas, you'll need to familiarize yourself with this. Yeah, target beta, purely beta, a lot of effect on the heart. It can decrease your systemic vascular resistance, and then that's why your effect on blood pressure is variable. Vasopressin, we don't have this. What's nice about it, the receptor V1, V2 is different to the previous drugs. So it doesn't work on the catecholamine system. Onset of action is within 15 minutes, but it can be up to an hour to reach peak effect. Main use here is to achieve vasoconstriction. Overseas, they use it as an adjunct after noradrenaline. The problem with vasopressin is there's no side effects. There's no there's no reversing agent. We'll get to the impact of that just now. Milrinone. So again, it's different to catecholamines. The receptor, it's a phosphodiesterase inhibitor. Onset of action is quite quick. Half-life is long. And the main effect is inotropy, but also reducing preload and afterload. So they use this in decompensated heart failure. It can lead to dysrhythmias and hypotension. A last resort that we can go to, methylene blue. It's a nitric oxide synthase inhibitor. Onset of action is 15 minutes with a very long half-life. It causes vasoconstriction, and the main shock use is refractory vasoplegic shock. And then it's also useful in metformin poisoning. A lot of side effects. It can impair your microvascular perfusion. It can increase mortality in septic shock, so it's not for use in septic shock. It can cause serotonin syndrome. It can lead to methemoglobinemia and then hemolytic anemia in patients with glucose 6-phosphate dehydrogenase. This is a new drug they're testing in America at the moment, angiotensin II agonists. They are testing it in septic shock. It works on your angiotensin I receptors. Onset of action is within 5 minutes to peak effect. Very, very short half-life, and they have no idea how it's excreted at the moment. Side effects, it can cause DVTs and tachycardia. This is what we've gone through just now. Something we're going to sit and read tonight. So how do we target vasopressor titration? There's basically two ways. We can do pressure targets and we can do flow targets. And it's not an either or. We should look at both when we use inotropes on our patients. And this should be individualized from patient to patient. Our pressure targets, so we always talk about MAP. Everyone talks about, let's go for a MAP of 65. And MAP of 65 is appropriate for most patients. The 65 trial and this is according to the 65 trial and the Sepsipam trial. A higher MAP is associated with increased risk for adverse events like acute kidney injury. But understandably, interpatient variability exists. The history of chronic hypertension does not indicate a reason for higher MAP targets. The Sepsipam trial, in the Sepsipam trial, patients with hypertension had a lower incidence of acute kidney injury if they targeted a higher MAP. So it just means their kidneys can tolerate higher MAPs. But patients with hypertension in the 65 trial had a lower 90-day mortality in the lower MAP group, pressure group. So if you can do a higher MAP trial in patients with a suspicion of persistent hyperperfusion. So let's say if you've started the inotropes, you're targeting MAP of 65, but there's still features of hyperperfusion. So there's worsening AKI, there's prolonged cap refill time, there's still altered mental state. Sure, then you can try a higher MAP. In patients with unstable coronary artery disease or chronic pulmonary hypertension, they say it's better to target a certain level of diastolic blood pressure and not to look at your MAPs. In literature, there's quite a lot of discussion on what targets we should check. So I think just discuss with your consultant if necessary. So that was our pressure targets. Looking at the flow targets, we can incorporate POCUS. So you can look at cardiomechanics. So you look at left and right ventricular function, your valvular integrity, cardiac filling, in any pericardial pathology. You look at volume responsiveness. So what is the IVC doing? What is your SVC doing? You can look at the left your LVOT, flow respiratory variations, and flow response to passive leg raising. You can measure the cardiac output. I'll show you a slide just now. And then the splanchnic Doppler resistive index. Let's move in now. Yeah, I think it's just go Google this, go look for YouTube videos now to measure the LV outflow tract area. Then you calculate the LV outflow tract VTI, and through some complex calculations, you can actually measure the cardiac output. And you can measure this before you start inotropes and after you started inotropes, just to see the effect. Clinically, you'll assess the patient's skin. So what is the cap refill? And then there's a mottling score you can do. Kidneys, what is the urine output? And brain, what is the level of consciousness and the patient's mentation? Your Doppler resistive index, so what is the flow through the kidneys? What is the flow through the spleen? And you can do calculations to see if the patient's perfused, hyperperfused, or underperfused. The hemodynamic effect of your vasopressors and inotropes. So basically, vasopressors induce an endogenous fluid recruitment by increasing the systemic vascular resistance and the vasoconstrictive effect of the venous system. And this increases the venous return and subsequently increasing the cardiac output. So you're basically simulating a fluid bolus when you start inotropes. Noradrenaline also decreases inflammation, induced capillary permeability. We need to stay away from giving too much fluids, and vasopressor use can limit the positive fluid balance. Sure, try a fluid balance, a fluid challenge to rule out hypovolemia, but start your vasopressors early, especially if your MAPs are 50, 55. They say you can start fluids, start vasopressors, assess your patient, and titrate down as necessary. After you've started your inotropes, you need to reassess fluid status and your cardiac output. Higher doses can cause excessive vasoconstriction, resulting in coronary, mesenteric, and digital ischemia. And then reduced myocardial perfusion or increased afterload will decrease your cardiac output. So sure, you start your inotropes, you've got MAPS of 65, blood pressure looks good, but the patient is not doing too great. So you need to reassess after starting your inotropes. When are we going to start a second-line drug? Second vasopressor agent with a different vasoconstrictive mechanism of action might limit the side effects of our catecholamines. In literature, the first-line vasopressor is noradrenaline. Our first line is adrenaline. After they've reached 0.25 mics per kg per minute, then they will start their second line. We generally, so we start our patients on adrenaline. Our second line would be dobutamine, especially if there's cardiac dysfunction. Evidence, so when to give a steroid, evidence suggests that hydrocortisone with fludrocortisone decreases the doses of vasopressors in patients with septic shock requiring more than 0.25 mics per kg per minute, and patients with multiple organ failure. So why add fludrocortisone? The Corticus trial showed no significant survival benefit from an 11-day course of hydrocortisone alone. There was an experimental study, it's the one on the screen, that showed marked down regulation of vascular mineralocorticoid receptors. Then the approach and the GER-INF-05 trials showed survival benefit from corticosteroid therapy because they added fludrocortisone to provide additional mineralocorticoid potency. Memorize this table. If you look at, so hydrocortisone is 1:1, glucocorticoid to mineralocorticoid, and then fludrocortisone, the one they added, is 125 times more potent than hydrocortisone on mineralocorticoid receptors. Fludrocortisone is it's a tablet, so they gave it oral via NG tube in their patients. Let's look at some myths. I think the most important thing now, just remember this, is we'll discuss what literature says, but go on what your local guidelines show. Okay, so discuss this with your consultant. Martin et al. Did a retrospective study, and they found that patients with septic shock requiring more than 1 mic per kg per minute of adrenaline had more than 90% mortality. But they did not look at any confounding factors. This was a retrospective observational study. Then some French people came and they did another study on patients requiring more than 1 mic per kg per minute for more than an hour. So they only looked at patients on more than 1 mic per kg per minute for more than 1 hour. And they found a mortality rate of 60% at 28 days. And 46% of those deaths occurred either because the doctors withdrew or withheld further care. So this shows fair survival for patients on very high doses of vasopressors. Just want to bring this one up. Okay, so this is the table of all the drugs they gave. If you look at the green line, weight-based maximum dose. So the maximum dose that the survivors got was 2.26 mics per kg per minute. More than double the 1 mic that we generally, 1 mic where we generally stop. You can see that the survivors was almost at 4 mics per kg per minute. The orange line, weight-based mean dose, 0.7 for the survivors and 1.5 for the non-survivors. So you can see that the non-survivors throughout had higher inotrope requirements. The yellow line, the first 24 hours weight-based mean dose, 1.12 for the survivors. So even though the max was 2.2, they dropped down very quickly, so that the mean over 24 hours, the first 24 hours, was 1.12. I think the key here is, sure, they went way above the general 1 mic per kg per minute, but this is only for patients where there's something that you can acutely address the problem in the patient, and then quickly come down with the inotropes. This is not for your 80-year-old with COPD, biventricular failure, and curve 5 pneumonia with septic shock. Yeah. Enteral feeding. When can you start feeding your patients on inotropes? This NutriRIA-2 trial showed early isocaloric enteral nutrition did not reduce mortality or the risk of secondary infections, but was associated with greater risk of digestive complications compared to parenteral nutrition. Piton et al. Did a post hoc analysis of this NutriRIA-2 trial, and they found that enteral nutrition, dopebutamin use, the SAPS-2 score of more than 62, and the HV of less than 10 were independently associated with acute mesenteric ischemia. So enteral nutrition is safe in our patients receiving inotropes less than 0.3 mics per kg per minute. There's only really a risk after if you use more than 0.3 mics per kg per minute. But the risk remains very low. The risk is significantly high with use of dobutamine, or in patients with multiple organ failure, or for the very high SAPS-2 score. But as we discussed earlier, you can use ultrasound to assess the splanchnic perfusion. And if there's perfusion, you can feed these patients. Let's quickly talk about peripheral administration. So the Lubani paper, they did a systematic review of literature from 1946 until 2014. And they showed that 90% of extravasation or local tissue injury events occurred where the line was placed distal to your antecubital fossa. The duration of peripherally run vasopressors increased the likelihood of events. So in 204 events over all these years, 9 occurred within the first 12 hours, then 18 occurred from 12 to 24 hours, and all the rest of the 204 occurred after 24 hours of peripheral administration of inotropes. A few months later, they published a single-arm consecutive study of ICU patients, and they followed a protocol where pressors were indicated. So they chose a vein bigger than 4 millimeters, and placement of your IV line was confirmed with ultrasound. They only used upper extremities, contralateral to the BP cuff, only 18 gauge or 20 gauge. They did not place the IV lines in the hand or the wrist or the antecubital fossa. So only forearm. And then the IV line IV access function was reviewed 2 hourly by the nurses, and immediately attended line extravasation with prompt initiation of a local protocol. And they only did maximum of 72 hours of peripheral vasopressor administration. And in the study, they had a 2% extravasation rate with no events of local tissue injury. They only tested noradrenaline, dopamine, and phenylephrine. Then Lewis found a 4% extravasation risk, with all patients recovering with conservative management only. So from these 3 studies, you can definitely start your vasopressor on a good peripheral line, proximal to the wrist, with frequent review of peripheral lines, and you have to stop infiltrated lines immediately. So on your peripheral lines, you can start most vasopressors on inotropes. It must be a well-running line. I always say this is the line that I put. Don't trust the line that anyone else has put. preferably proximal to the wrist. And I also don't like antecubital fossa lines. On your midlines, midlines so far appear to be safe for all inotropes. Central lines, vasopressors should only be placed in a central line. That is because there's no reversal agent for vasopressin. And you don't have to wait for access, central line access, before you start your other inotropes. Intraosseous, you have to be really sure that it's in and not extravasating. If it's a deep intraosseous and you start your inotropes, it might be a while before you notice it's extravasating. So you really have to be sure that your IO is in. What do you do in case of extravasation? So you stop the infusion and you switch to another line, but don't pull out the cannula. You suck out as much as you can. So you leave your Jalco in, you take a 5 ml and try to aspirate as much as you can. And then administer phentolamine, 0.1 to 0.2 mics, a milligram per kg, maximum of 10, so maximum of two bottles like this. Subcut around the site and through the cannula. I've never seen this. I've never had to use this. I don't even know if you've got it. Take note that it may cause systemic hypotension. And after you've gone through that, then you can take out your Jalco and then elevate the arm and consult plastics. This is a grading for extravasation. So grade 1 is intact skin, grade 5 is death, and everything in between. This is the flush out technique. So you leave your Jalco there, you make holes around the area, and you can flush out. They say you use dilute hyaluronidase, but I'm sure you can just try and flush out saline as well. You can numb the area with lignocaine, without epi, of course, and then inject around and then flush it out, and then obviously plastics afterwards. I think the most important thing for this discussion is you have to assess your vasopressors requirements early. You have to start your vasopressor early. So start with your fluids. If match is low, you start with your fluids. You give your fluids and then titrate down your vasopressors as needed. You assess the patient and and either titrate up with your inotropes or titrate up with your fluids, depending on what the patients need. You have to reassess the response to your vasopressor. And an increase in blood pressure is not necessarily an adequate response. You have to look at your flow parameters as well. And then you have to address the cause of shock. Vasopressors and inotropes is not, it's buying you time. It's not a treatment. Some references that I know no one always ever goes through, but this is what I used. Do you guys have any pressing comments or questions?
I'm going to jump in, Fred, and say thank you very much for giving us your talk. It's really cool because we had a talk earlier in the year just on sort of a very practical, basic approach to adrenaline, how to draw up a push dose vasopressor, how to use an adrenaline chart, but we didn't really go into physiology and essentially effectiveness or indications for different kinds of vasopressors and inotropes. So there's a very basic talk that we did, and you kind of have gone in a lot more depth, and it's been really cool for our guys. I'm going to give the team an opportunity to make comments or ask questions. Hey guys, now's your time to shine. Andy?
Morning. I don't have any immediate questions that come to mind. Just thanks for the presentation.
Cool. Anybody else? Charlie, Christelle, anybody that wants to ask a question or make a comment? Okay. So I'm going to make a comment just about the phentolamine. I've never seen it being used, even in an ICU or theatre setting. I have a strong, sneaky suspicion that phentolamine was removed from the South African market more than 10 to 15 years ago. I could be wrong. Yeah, but it is something that might potentially be available if you're working in another environment. Okay, Fred, I'm going to say thank you so much. I really appreciate it. I'm going to exit from my side. Everybody else, thank you for joining us for the teaching. Please feel free to leave. Fred, please do save it and then send me the link for the talk.
All right, cool. I'll do that. Thanks, everyone.
Cool beans. Thank you. Bye.
Thank you.